Thank you very much for inviting me to speak today. I think actually I think the order has turned out really well because we can start to be building a little bit of a story here because I work in the same area or related area to Marco. As a background, I'm an academic. I work in medical image analysis, sort of computer vision. And I've also previously worked in industry and had a spin out in ultrasound AI. By that, I mean AI that tries to make ultrasound devices easier to use. So I've had a variety of experiences, but what I particularly wanted to focus on today is my academic work, which is very much interdisciplinary. And that's one of the things that I think I wanted to bring across in terms of thinking about healthcare AI governance and how you start to develop and deploy solution. Everything's about interdisciplinarity. And at the moment, my background in engineering, I work with clinicians, and I've done that for many years. But more recently, I'm now working with experts in human factors and experimental psychology, and that's about co-designing the right solutions or trying to co-design more appropriate solutions for healthcare. So I think the conversation we're having about proportional approach to ethical AI requirements is an incredibly timely conversation. And I think we all need to be part of that. It's not about one part of the community telling the other what to do. And these interdisciplinary conversations are important to understand how to move things forward. So I've got a few thoughts on this topic based on the area I work. But I think, first of all, you touched on this at the beginning when you were introducing the topic, that healthcare is quite a special application of AI. And we also need to bear in mind when we talk about ethics. In healthcare and healthcare research, I've been talking about ethics for a long time. Clinical ethics has been there for many, many years. And then we've been talking about data and the data governance. And now we've extended that to the algorithms by talking about AI. And maybe we interchange the two and we say AI is about data and algorithms. And although this sounds like it should be a good platform, it also does cause some confusion because the ethical questions and the ethical committees sometimes don't always have the right expertise to evaluate these topics. And I think that is unique to healthcare. You touched also on this AI definition up front of defining AI. And if you talk in the space, people talk about clinical AI a lot. And they do get muddled again between, do they mean deep learning for risk stratification? Do they mean generative AI, large language models to help write reports? Or do they mean machine learning? And I think going forward, we do need to disentangle some of this, not in the computer science sense, but in the language sense to make sure that when we're talking about particular type of AI, we're on the same wavelength. And then the other thing that I think is very important when we talk about healthcare AI in its general sense is AI is good at decision making, but a lot of medicine's about judgment. And that does also get into some ethical issues about, are you really making a judgment when you make a healthcare decision? Or are you basing it on much more the decision making with the evidence behind it? And that brings in the human AI element of thinking about healthcare AI. So I just wanted to make some more specific points then. First of all, where are we in adoption and deployment? We've heard from the previous speakers about the companies who are starting to deploy solutions, but we must bear in mind that the AI technologies that we're trying to deploy, they are emerging technologies. And some of it's still very much tech push. It's not about co-designing solutions. And we're going to go through another iteration of as well. There are lots of small companies developing tools and some large companies, but there are a few real world deployment case studies. If you look at the literature, that really, and the ones that are thorough do highlight that it isn't easy to adopt tech. And I just want to, as an example, there was a recent Lancet paper published this year that considered the procurement and early deployment in the UK NHS of AI tools for stress radiology diagnostics. I do recommend you look at this. And what that study highlights is there are technical challenges in deployment of getting systems into place, but there's also the social complexities surrounding the introduction of AI into the workplace. What this study concluded was that while introducing AI into a clinical setting is similar to introducing other healthcare innovations, the relative novelty of AI, and this relates to policy, regulation, service level changes, create unique challenges in AI deployment today. And it's because it's early, we're all learning. And if I quote from this paper, the paper said, AI may not address service challenges as straightforwardly as policymakers anticipate. And that's because of the complexities today as we learn how to use the technologies. We want to use them. We've got to figure out the best way to do that. The second point I wanted to talk about was human oversight. And when we talk about AI, we often talk about AI safety. That means the safety of the tech. Whereas in healthcare, the most important thing is to focus on patient safety. And that's a little bit different. And patient safety is more to do with the human and AI interactions. And in other words, the human factors need to be considered. And we mustn't forget that when we're talking about AI governance, that it needs to extend to consider these issues. And this links to actually the point that was made in the plenary yesterday, that we need to be focusing on the purpose of the AI and why use the AI in the first place, because you can have a great tech solution, but it doesn't have much, it might not have much influence on healthcare practice. And human oversight gets into the conversations related to deployment, but looking at how do humans trust and how do they become reliant and over-reliant on AI. There are, again, relatively few studies because everything's emerging, and they seem to draw different conclusions on whether humans trust AI or whether they don't. Some of that's to do with study design. If it's a small study, the particular maybe biases in the study design, but also human trust and reliance depends on the task, context, and even to the individual's attitude towards tech and their individual's trust profile. So there's a lot to learn if we want to be thinking about the safety of the patient when we introduce AI. And then the final point I'm going to mention relates to the citizen and patient empowerment. This particularly relates to using large language models. Large language models really do allow a patient to look up healthcare information and provide self-help. We can think of this as being very positive, but we do need to be careful that the information people are looking at is correct. That's so there's a positive and slight negative there. And maybe there is an issue about regulation and the what healthcare information is allowed to be able to protect to be given with general AI. But along with that, in empowering the patient, it also means that patients are telling a doctor what healthcare they want. And this, of course, is potentially dangerous if a general large language model is used where we haven't got guardrails up. And it's also, importantly, it's starting to challenge patient trust in healthcare professionals. And hence, potentially, it's a risk for patients trusting healthcare systems and taking ownership of their own healthcare as well. So when we talk about the trade-offs between risks, regulation, but also providing solutions, we really do need to think deeply about this point. One final point, which was touched on by Wendy Hall in the plenary, was accessible AI and the global ethics. And this, again, is, to me, a very important issue as someone who also works in global health. And that's how do you build solutions? First of all, the easy one, I think, how do you build solutions of different populations? People have been talking about this, that the fact the data that's built on it might be from European healthcare, but then the application might be in an African context, for example. But we need to better understand how to build solutions efficiently. And because the way you treat in Europe will be different than the way you'll be treating patients in another setting. But another question to do with, again, it's more to do with large language models, is how do you manage some of the cultural sensitivities which the current global models, largely built on Western data, do not really currently understand how to provide the citizens or the doctors with the correct information. So the information might be accurate, but the context, applied in the context, it isn't the right thing to do. So we also need to think about that as well from an ethical point of view. So on that note, I would thank you for listening to me, and I enjoy participating to the questions later. Thank you.